In the boot camp course, we explored both the origins of the radiological 5 mm definition of Chiari and the limitations of this definition. Specifically, we learned that research has repeatedly shown that in Chiari the amount of tonsillar herniation is not strongly related to symptom severity. We also learned that only a fraction of people who meet the radiological definition of Chiari will ever experience symptoms. Then, in the last module, we evaluated the 5 mm test quantitatively, as we would any other disease biomarker. In scientific terms, we found that tonsillar herniation is a necessary, but not sufficient, component of symptomatic Chiari. In this module, we will turn our attention to the efforts of researchers to go beyond tonsillar position in attempting to explain Chiari at a fundamental level and to improve diagnosis and treatment. Not surprisingly, a large portion of these efforts have entailed looking for other radiological markers that are indicative of Chiari. At the highest level, these markers can be classified as either static, meaning measures of basic anatomy, or dynamic, meaning a measure of an active process in the human body. We will start by looking at the static measures, commonly referred to as morphometrics. Morphometrics means the study of the dimensions and shapes of living organisms and their anatomy. So with Chiari, morphometrics involves taking quantitative measurements of the skull, brain, and spine from imaging. Morphometrics is one of the most active fields of Chiari research, and a quick literature search with the keywords Chiari morphometrics returns well over 100 publications. In Chiari, morphometrics research includes many different types of studies that can be categorized according to their purpose, imaging technology, and subjects. For example, in terms of purpose, morphometrics can and has been used to identify differences between Chiari patients and healthy controls, identify differences between different groups of Chiari patients, explore the causative mechanisms of specific symptoms, and identify predictors, both positive and negative, of surgical outcome. Meanwhile, the imaging technology can include, but is not limited to, different types of MRIs, CT scans, and even X-rays, while the subjects can be pediatric Chiari, adult Chiari, healthy controls, and though harder to find, people with tonsillar herniation but no symptoms. Any given study can be a mix and match of these components. For example, a study might look at morphometric predictors of syringomyelia in pediatric females using conventional MRIs. Another study might use CTs to look for differences in the cervical spine between adult Chiari patients and healthy controls. Because morphometrics has such a broad scope and includes so many published studies, for the purposes of this module, we will focus primarily on the morphometric differences between Chiari patients and healthy controls. We will further refine our focus to mainly adults. From a research point of view, studying children is much more complex, and therefore more data is available on adult patients than pediatric ones. The origins of this type of research in Chiari can be traced back to the neurosurgeon Thomas Millerat's landmark publication in 1999 on 364 patients. While the study included detailed clinical records and genetic testing, it also included a quantitative analysis of the posterior fossa and CSF spaces of 50 Chiari patients compared to age and gender-matched controls. Recall that the posterior fossa is the area in the back of the skull that houses the cerebellum and brainstem. Millerat found that the average posterior fossa volume for Chiari patients was smaller than the healthy subjects, but that the brain volume was the same. From this, he theorized that the posterior fossa region for Chiari patients doesn't develop to its full size, and the normally growing brain herniates out of the skull in response. He also found that every Chiari patient had reduced CSF space around the herniated tonsils. His finding that CSF spaces are reduced in Chiari patients has been shown to be true repeatedly over the years, but the small posterior fossa finding and theory is not as cut and dried. Over time, not all studies have found this to be true, and it appears that not every Chiari patient has a small posterior fossa. In addition, studies of large hospital imaging databases have shown that tonsillar position is normally distributed in the population much like height, with nearly 1% of adults and even more children having a tonsillar position of 5 millimeters or more below the foramen magnum. This calls into question the small posterior fossa theory, or at the very least indicates that something else is going on as well. Over the ensuing years, morphometric analysis of Chiari has expanded to include many measures and evolved to use sophisticated software. Since Chiari does involve the cerebellar tonsils, most morphometric analysis is focused on the posterior fossa, skull base, and craniovertebral junction. In general, morphometrics research has identified 5 major areas where adult Chiari patients tend to have abnormal anatomy: the height of posterior fossa structures, the size and angle of the clivus bone, the amount of space available for cerebrospinal fluid, the Odontoid process, and stabilization of the Atlanto-occipital and Atlanto-axial joints. If we look at a mid-sagittal MRI, which is essentially the head cut in half from nose to back, the posterior fossa is a 5-sided shape defined by the clivus bone on the left, the foramen magnum or Macrae line at the bottom, the occipital bone on the right, the tentorium, which separates the cerebellum and the cerebrum, across the top, and finally a non-anatomical line connecting the top of the clivus and the tentorium. From this, researchers have looked at the length of the individual posterior fossa components, such as the clivus bone length, Macrae line length, and occipital bone length, and of course the posterior fossa height, width, and area. Several studies have noted that in adult Chiari patients the clivus bone is significantly shorter and the Macrae line length is significantly larger compared to healthy controls. Specifically, a large Conquer Chiari Research Center study of over 300 adult female Chiari patients and controls found that the clivus bone was about 3 millimeters shorter and the Macrae line 1 millimeter longer on average with Chiari. For the occipital bone, results have been mixed. Some studies have found it to be shorter in Chiari patients, but other studies have not found a difference. For the posterior fossa, the Conquer Chiari study found that while the height was significantly shorter in Chiari patients, the overall area was not significantly different. As we learned earlier, the Macrae line is used as a reference to measure tonsillar position. The Conquer Chiari study went further and used the Macrae line as a reference to measure the distance to 3 locations above the line, rather than below. Namely the fastigium, which is a point where the 4th ventricle meets the cerebellum and is easy to see on an MRI, the pons, which is part of the brainstem, and the corpus callosum, which connects the right and left hemispheres of the brain. Much like the clivus bone, in Chiari patients, these distances are reduced on average by about 3 millimeters, meaning that the entire hindbrain sags or sits lower, not just the cerebellar tonsils. Interestingly, one study found that these posterior fossa height reductions are even more pronounced among Chiari men, even though among adults, Chiari predominantly affects women. The clivus bone has been the focus of several morphometric studies. The clivus is part of a skull base, which slopes up and backwards from the foramen magnum in the middle of the skull. In fact, clivus means slope in Latin. The pons, which is part of the brainstem, essentially sits on the clivus, and the pituitary gland is located above the top of the clivus. Research has shown that in addition to being shorter in Chiari patients, the clivus bone can be angled differently. The clivo-axial angle is a widely used clinical measure, which shows the angle of the clivus bone relative to the top vertebra. Studies have shown that the average clivo-axial angle among healthy adults is around 150 degrees, and that a value of less than 135 degrees can indicate brainstem compression. Changes in the clivo-axial angle, as the head tips forward and back, can also indicate cervical instability. The clivus angle can also be measured relative to the Macrae line. This is known as the Bugard angle. The average Bugard angle in healthy people is 126 degrees, and the medical consensus is that a Bugard angle of 136 degrees or more indicates flattening of the skull base, also known as platybasia. With both angles, the average among Chiari patients is significantly different than healthy controls, but it is not beyond the radiological cutoffs mentioned above. However, there is tremendous variability in these angles among Chiari patients, and a subgroup of patients clearly do have abnormal Clivus angles. In fact, data from the Chiari 1000 indicates that out of 474 adult female Chiari patients, a little more than 7% have a Clivo-axial angle of 135 degrees or less, and a similar percentage have a Bugard angle of 136 degrees or more. In addition, more than 10% are within 5 degrees of these somewhat arbitrary thresholds. While these MRI-based findings are significant, a Conquer-Chiari study of the Clivus bone using CTs revealed even more dramatic differences. Bones can be difficult to measure on MRI, but CTs, which are a fast series of X-rays controlled by a computer, allow for very precise measurements of bones. This study compared the Clivus bones of 30 adult female Chiari patients to 30 age and BMI match controls. The study found that the overall Clivus volume of the Chiari group was 31% smaller on average than the control group. This difference can be readily seen in these side-by-side images of a Chiari Clivus and a healthy control Clivus. The same study also looked at the sphenoid sinus, which is a sinus cavity directly opposite the brainstem on the other side of the Clivus, and found that the sphenoid sinus was 38% larger in the Chiari group. Finally, the study looked at the area of the sella turcica, which is a saddle-like structure at the top of the Clivus where the pituitary sits. In the Chiari group, this area was reduced by 27%. It is not clear what effect this reduced area has on the function of the pituitary in Chiari patients, if any, but it is interesting to note that the average BMI of Chiari patients is significantly higher than the national average. Interestingly, a short Clivus bone seems to be one of the only morphometric measures consistent across Chiari patients with different comorbidities or related conditions. A 2018 study used data from the Chiari 1000 to compare 28 morphometric measures of over 200 adult female patients to healthy controls. Additionally, the Chiari patients were grouped by several related conditions, including syringomyelia, EDS, intracranial hypertension, scoliosis, and cervical instability. Interestingly, only 4 measures were consistently different from controls across the different related condition groups, with a short Clivus being one of them. Finally, a 2020 Conquer-Chiari study found that a short Clivus may distinguish healthy adults with low-lying tonsils from symptomatic Chiari patients. This study evaluated 7 morphometrics measures on 210 adult females with symptomatic Chiari and 90 female controls. The subjects were divided into 4 groups. Healthy controls with a normal tonsillar position above the Macrae line. Controls with low-lying tonsils, defined as a tonsillar position of 1 to 5 millimeters below the Macrae line. Chiari patients with a tonsillar position of 1 to 5 millimeters. And finally, Chiari patients with a tonsillar position of 6 to 13 millimeters. All 7 morphometric measures were significantly different between the Chiari group with severe tonsillar descent and both control groups. The Chiari group with tonsillar position between 1 to 5 millimeters had 4 measures that were significantly different from the control group with normal tonsillar position. However, between the Chiari and control group with similar tonsillar position, meaning 1 to 5 millimeters, Clivus length was the only measure that was different. While these studies seem to indicate that the Clivus bone may play an important role in symptomatic Chiari, the details of this connection remain a mystery. For example, it is not clear if the loss of Clivus volume is from the bone not developing properly during childhood and this then somehow contributes to symptoms, or if the abnormal CSF pressure environment that exists with Chiari interferes with the natural growth and resorption of the Clivus bone, and the loss of volume is a biomarker of altered pressure environment. Speaking of CSF, next let's turn our attention to the CSF system, and specifically the spaces around the craniovertebral junction. Recall that CSF stands for cerebrospinal fluid, which is a clear liquid that circulates under the dura, bathing, protecting, and nourishing the brain and spinal cord. In a healthy adult, there is a fairly large collection of CSF just below the foramen magnum, on both sides of the spinal cord. On a mid-sagittal MRI, these spaces can be referred to as the posterior, meaning behind, and anterior CSF spaces. In Chiari, the herniated tonsils reduce the amount of space available for CSF in the posterior region. In some patients, this reduction is minimal, while in others the available space is completely occupied by the herniated tonsils. If we measure the area of the posterior CSF space between the foramen magnum and the bottom of the second vertebra, on average, there is a 25% reduction in adult female Chiari patients compared to healthy controls. Restoring this space is a major goal of Chiari surgery and why some surgeons choose to remove part of the tonsils during the procedure. Interestingly, in adult female Chiari patients, the anterior CSF space is also reduced by an average of 20%. What causes the anterior reduction is not clear, and there is also evidence that this reduction occurs primarily in adult women, not adult men, or children with Chiari. Before we discuss the final two areas where Chiari patients tend to have altered morphometrics, we need to take a moment to review some anatomy around where the skull meets the spine. Head movement involves two main joints, the atlanto-occipital joint and the atlanto-axial joint. The atlanto-occipital joint is where the skull, or cranium, rests on the first cervical vertebra, also known as the atlas. Basically, the cranium has two protuberances, one on each side, called condyles that sit into depressions on each side of the atlas. This enables the head to move forward and backward. The atlanto-axial joint is the connection between the top spinal vertebra, the atlas, and the second vertebra, known as the axis. The axis has a bony projection called the Odontoid process that passes through the atlas and enables rotational movement of the head. The two joints and their associated movements are controlled and stabilized by the cervical paraspinal muscles, the suboccipital muscles, and a series of ligaments and other connective tissues. Starting with the odontoid in Chiari patients, or more accurately a subset of Chiari patients, the odontoid process can push too high into the skull base in what is called basilar invagination. It can also be angled in towards the spinal canal and brainstem in what is called retroflexion. This can cause compression of the brainstem from the front side and can lead to the brainstem bending or kinking around the odontoid. This subset of patients, which some clinicians call complex Chiari, may also experience cervical instability and often require additional surgical procedures to relieve the pressure caused by the odontoid and to stabilize the cervical spine. In general, the morphometric measures that have developed around the odontoid process are more clinical in nature as opposed to having a research focus. As such, they tend to have specific cutoff values which are suggestive of basilar invagination, brainstem compression, or instability. In general, they are used to help surgeons decide when additional procedures are necessary. For example, with basilar invagination, several measures have been suggested that involve where the top of the odontoid is located, relative to a horizontal line on a mid-sagittal image, such as the McRae line. If the top of the odontoid is above one of these reference lines by a specific amount, then it is suggestive of basilar invagination. A large German study of over 300 adult surgical Chiari patients found that 14% met one of the most common imaging definitions of basilar invagination. However, it is important to note that this was surgical cases only, so if non-surgical cases were included, the percentage would likely be much lower. For ventral brainstem compression, meaning from the front, Grab-Oaks is one of the most used measures. Grab-Oaks is a distance that assesses how far the tip of the odontoid pushes into the spinal canal, and a value of more than 9 millimeters is considered suspicious for brainstem compression. Data from the Chiari 1000 indicates that about 11% of adult female Chiari patients have a Grab-Oaks measure of 9 millimeters or more. However, the same data reveals that the average Grab-Oaks distance for the Chiari group is not significantly different than for healthy controls, and is well below the clinical cutoff value. So much like with the small posterior fossa, not every Chiari patient has odontoid irregularities. Instability of the atlanto-axial joint is a recognized issue among a subset of Chiari patients, but does not have a widely accepted morphometric definition. Certain static measures can be suggestive of cervical instability, but the research is mixed in how useful these measures are. If cervical instability is suspected, some surgeons will order dynamic MRIs, which are a series of scans taken with the head and neck in different positions. But again, there are no widely accepted criteria for when a dynamic MRI should be used or how to interpret the results. The role that cervical instability may play in symptomatic Chiari will be discussed more in a later module when we are reviewing Chiari theories, but currently it is not clear if odontoid and cervical instability issues are limited to a small subset of Chiari patients or if small anatomical variations in this region are important and thus involve more Chiari patients than initially suspected. There is research that indicates Chiari patients in general may have subtle instability issues around the atlanto-occipital and atlanto-axial joints. For example, the paraspinal muscles are the groups of muscles that surround the spine, enabling movement and providing stability. One small study found that the cervical paraspinal muscles were smaller on average in Chiari patients than in healthy controls. The study also found that the reduced muscle mass was more pronounced in patients with neck pain than in those without neck pain. However, it is not clear if the reduced size and presumably strength occurs developmentally and is part of Chiari anatomy, or if it is a result of nerve damage due to the herniated tonsils and altered CSF pressure environment. In this study, there was a modest correlation between duration of symptoms and reduced muscle size, suggesting that it could be due to loss of nerve function in the affected muscles. Research has also found altered stabilizing ligaments and membranes in Chiari patients. The transverse ligament spans across the top vertebra, the atlas, and is the main source of support for the odontoid process. The alar ligaments connect each side of the foramen magnum to the odontoid process. One study found that the transverse ligament is about 7% shorter, and the alar ligaments are 18% shorter in Chiari patients compared to healthy controls. Meanwhile, the posterior atlanto-occipital membrane is a broad membrane that connects the back of the skull to the back of the top vertebra. It is routinely removed during Chiari surgery, and a microscopic analysis of removed samples found the connective tissue fibers that comprise the membrane were disorganized in Chiari patients, meaning oriented in different directions rather than parallel, and that the membrane had a higher fat content than normal. The cause and effects of these ligament and membrane alterations in Chiari need to be researched further. Finally, a Chinese study found that the atlanto-occipital joints, meaning where the occipital condyles fit into the depressions on the atlas, are nearly 40% more shallow in Chiari patients than healthy controls. This suggests that many Chiari patients may have subtle instability in this joint, and unlike the muscle and ligament alterations, this bony abnormality is more likely to be a contributing factor of symptomatic Chiari than an effect of it. In most of the studies discussed so far, Chiari patients were compared to healthy control subjects. But to look beyond tonsillar position, it would be beneficial to look at people with tonsillar herniation greater than 5 millimeters, but without symptoms. Some studies have used hospital records to identify such cases. But then the question becomes, if they are in the hospital, are they truly asymptomatic? Or did a doctor just decide the symptoms were not due to Chiari? Conquer Chiari researchers found a way around this dilemma by leveraging the Federal Adolescent Brain Cognitive Development Study. The ABCD study, as it is called, involves over 10,000 adolescents recruited through schools throughout the U.S. who undergo MRIs every 2 years and are evaluated for a broad range of physical, mental, and behavioral issues. Using this massive database, the Conquer Chiari researchers identified 106 adolescents with tonsillar position greater than 5 millimeters. They then pulled 106 controls from the same database who were matched individually by age, sex, BMI, race, and ethnicity. None of the subjects with tonsillar herniation displayed any symptoms or were different in any way from the controls in terms of health and behavior. However, morphometric analysis found that their anatomies were strikingly like what is seen in adult Chiari, with short clivus bones, reduced CSF spaces, etc., indicating that a Chiari-like anatomy, even beyond tonsillar position, does not always cause symptoms. In fact, researchers have struggled to connect morphometrics measures to specific symptoms, overall symptom severity, and surgical outcomes. While research has identified many anatomical differences in Chiari patients, a lot of these differences are small in absolute terms. So even though they may be significantly different in a statistical sense, that does necessarily equate to a meaningful difference. It's also important to keep in mind that Chiari patients are a varied group. So, while some may have small posterior fossas and others may have odontoid irregularities, for pretty much every morphometric measure, there are patients who are within the normal range for that anatomical feature. For example, a Conquer Chiari study of over 400 adults found that while the average clivus length is significantly shorter for Chiari patients, more than 60% of the same Chiari patients had a clivus length well within the normal range. Overall, it appears that an altered anatomy in the craniovertebral region, like tonsillar herniation, is only part of the story when it comes to Chiari. That is why some researchers have begun to look at dynamic processes in Chiari patients to understand how and why people become symptomatic, which is the subject of the next module. To summarize what we learned in this module, many Chiari patients have anatomical differences compared to healthy people that extend beyond the herniated cerebellar tonsils. Significant findings in static morphometric studies include reduced posterior fossa volume, clivus bone anomalies, alterations in CSF spaces, and abnormalities in the odontoid process and Atlanto-axial joints. However, it has been difficult to link these differences to specific symptoms or outcomes. Further research is needed to better understand the implications of morphometric differences in Chiari.